So, killer EKGs. I think EKGs are largely underutilized in emergency medicine and particularly in pre-hospital. Pre-hospital, when you guys do an EKG, why are you doing it? What are you looking for? STEMI, right? STEMI yes, STEMI no. What else can you see on an EKG? Lots of things, right? So what I'm going to be talking about today are immediate life-threatening diagnoses that you can get from the EKG that aren't STEMIs. So specifically, we're going to be talking about pulmonary embolism and hyperkalemia. First, I'm going to be talking about test characteristics. That's kind of statistics, but I promise it's firefighter friendly. This is just so that you can understand how accurate these tests are at telling you one thing or another. So the two words that we use to describe the accuracy of a test are sensitivity and specificity. Has anyone ever heard those words when someone's talking about research? Something sensitive versus specific? Maybe heard those thrown around? Okay. So a test that is very sensitive is something that detects everyone that has the disease and then some. So you tend to get false positives with these. These are screening tests. So pregnancy tests, anyone know someone, maybe a friend, that had a positive pregnancy test and then it turns out they weren't? Yeah, that's a thing. So those are designed to be screening tests. They're very sensitive. Has anyone ever, in healthcare, so we're all getting TB tests all the time. Anyone work themselves or work with someone that's had a positive TB test that was a false positive? Yeah, all the time. So those are screening tests because those are high-risk, low-frequency things that you don't want to miss. So we're okay with having some false positives because they're designed to screen things out. So those are tests that are really sensitive. On the flip side, you've got tests that are very specific. And these very accurately identify people with the disease, but you tend to actually miss some people with the disease. But you're really sure about all the people that you accused of having the disease. They're all going to have it. Whereas just the last time we had false positives, this time we don't have false positives, we have false negatives. So let's relate this a little bit. If we were trying to create criteria to decide if you have a broken arm, what would be a very sensitive question to ask in the history? Do you have arm pain, right? So do you have arm pain, and the answer is no, do they probably have a broken arm? Probably not. Might there be some people? Yeah, but by and large, no arm pain? Yeah, they probably don't have a broken arm. Okay, fine. So what would be a presentation that would be very specific to a broken arm? Yeah, like exposed protruding bone ends, okay? Every single one of them, they got a broken arm. But if you define that as being broken arm, how many breaks would you miss? Probably a lot. Okay, so that's sensitive versus specific. To drill it home again, NIH Stroke Scale. So this is a 0 to 40 scale that neurologists use to rate how bad is your stroke. So on the 0 end, this is someone with a really vague, not so bad presentation. You're looking at them, you're like, could be a stroke, could be low blood sugar, could be alcohol, could be lots of things, right? It's kind of vague. If we called a stroke on every single one of those people, we would catch all the strokes. We would also accuse a lot of people of having a stroke that weren't. On the opposite end, up towards 40, this is they're off balance, having vision changes, facial droop, pronator drift, slurred speech, classic textbook stroke presentation. Okay, we're really sure that that person's having a stroke. But there's a lot of people that might be having something more subtle, but they still have the same disease process. So you can see how on the vague end, it's very sensitive, and on the textbook definition end, it's very specific. So that's what those things mean. So as I go through this, and I'm talking about these EKG criteria, and this is specific or not sensitive, or this is sensitive and not specific, I'm going to talk to you about, so you can use this to rule in a disease, or you can use this to rule out a disease, so that you understand which way to use it. Because very few tests are sensitive and specific, so the test result literally means you do or don't have the disease based on that one test. That's actually really unusual. So the other thing to mention is pretest probability. What does it mean if a guy pees on a stick and gets a positive pregnancy test? Right, well, it might mean that he actually has testicular cancer, but does it mean he's pregnant? No. Why? Because the pretest probability of a man being pregnant is 0. So that population is so low risk for the thing you're testing for that your test can only produce a false positive. Okay? So anyone ever done an EKG on someone that just had like really vague complaints or was super young and healthy, and you did it just because you thought maybe someone would want an EKG, and then it came up with some kind of abnormality? Yeah. But then that abnormality had nothing to do with what was going on? Yeah, happens all the time. So people that are really low risk for something that have a positive test are still really low risk. So, and people that are really high risk, like anyone ever diagnosed a STEMI like before the EKG was done? Yeah, right? So they're a Honda, highly obese, non-compliant, diabetic alcoholic, and they've got dull-crushing chest pain that radiates to their arm and jaw, and they're diaphoretic and leaning over, and they're clutching their chest, and they say, I have this sense of impending doom, right? So you can call it almost without the EKG on that guy, because he's so high risk that even if his EKG was normal, you would still have kind of a suspicion that was going on. So that's the idea of pretest probability. So with that in mind, let's talk about the risk factors for pulmonary embolism. So there's 2 big studies that are done that have made these decision aids for deciding do you or do you not have a PE. One is called the Wells score. And these are, you don't need to memorize the numbers or anything. You can, if you do that, I mean, you can find out what the percent likelihood is that someone has a PE. That's not the important part. What I'm trying to get across here is that these are some of the risk factors that are associated with PE. So tachycardia, immobilization, a history of PE or DVT, coughing up blood, hemoptysis, or malignancy. What's malignancy a fancy word for? Cancer. Okay, cancer patients are at a 5 to 20 times higher risk of thrombotic events compared to the general population. So cancer patients, shortness of breath, maybe PE. Okay. The other well-studied thing is called the PERC rule. This one is written in a way to rule out pulmonary embolism, so these are like negative findings, but you can still see a lot of the same things. Tachycardia, older age, hypoxemia, coughing up blood, exogenous estrogen use. So anyone that's taking any kind of hormone replacement therapy, previous PE or DVT, recent surgery or trauma in the past several weeks, or one leg versus 2 leg swelling. If both legs are swollen and they're short of breath versus one leg is swollen and short of breath, which do you think is more likely to be a clot? One leg. It's probably unusual that you would happen to get identical clots in both of your legs. So looking at the data for this, the top 3 things that were the strongest predictors in terms of your history for putting you to have PE one way or the other was previous history of PE or DVT, unilateral leg swelling, and estrogen use. Those were the top factors. Everything else really didn't help that much. Even tachycardia, hypoxemia, coughing up blood, all that stuff wasn't particularly good at pushing up the likelihood that you have a PE. Now, surgery and cancer I highlight here because I think those are things that we don't often think about. But if you go on someone who, when you're doing your eval, they're complaining of shortness of breath, and then you see they have this big scar that looks kind of fresh, Ask if they recently had surgery. Could be a PE. If they're a cancer patient that you've picked up several times for whatever, but this time it's a little bit different, and they seem really short of breath, or something, could be a PE. So, how does this present on an EKG, right? So, has anyone ever heard of S1Q3T3? Yeah, okay? It's sort of like the classic textbook PE finding. So you've got a large S wave in lead 1, a large Q wave in lead 3, and an inverted T wave in lead 3. That's what that means. And that is associated with people having PE. The next one, which is what I see more often, is T-wave inversion in a very particular pattern. So we've got T-wave inversion in V1 through V3 and some in V4, but we've also got T-wave inversion in the inferior leads, most notably here in 3 and AVF. So this kind of J or L-shaped pattern of T-wave inversion kind of it suggests PE. Another thing that you wouldn't be able to tell in the field, but a new right bundle branch block is associated with PE. So in the hospital, they may be able to compare it to the patient's previous EKG, but this person's got a right bundle, and if it's new, it could suggest that they have a PE. So how accurate are these things? So it turns out they're fairly specific. So if you see this, that patient is fairly likely to be having a PE depending on their clinical presentation. Because, so if you've got a 17-year-old and they just broke up with their boyfriend and they're experiencing shortness of breath, but they have that pattern of T-wave inversion, are you calling them, saying they have a PE? They need to go to angio, get their clot busted? What do you think? No, they're low risk to begin with, so that positive test is kind of meaningless. But someone, cancer patient, just got a flight from Australia, didn't wear their pressure stockings, one leg swollen, and they just started hormone replacement therapy, and now they're complaining of shortness of breath, and they're tachycardic. What are you already thinking? Probably already thinking it's a PE. And then you see that pattern, now you've nailed the diagnosis. So you have to use the test in the context of the history and the exam. Neither one can really stand on their own. So all these criteria are fairly specific, but they're not sensitive. So what this means is if you find these things, you can accuse someone of having the disease. If you don't find them, that doesn't mean they're okay. So the cancer patient that just got a flight from Australia and has hormone replacement therapy and everything, if their EKG is normal, could they still have a PE? Yes, absolutely. So other EKG changes that are particularly associated with badness in the setting of PE, ST elevation in V1 and AVR, and ST depression in V4 through V6 are indicative of someone who's going to deteriorate into cardiogenic shock. So this is going to be probably the big saddle embolus, and they're going to get hypotensive, maybe code. So this is the one we were actually just looking at. You've got ST elevation in AVR and some in V1, which they're both kind of on the right side, so that makes sense. And then you've got this lateral ST depression here, so V4 through 6. So this person is not in a good place. This pattern, this AVR and V1 and some lateral ST depression, does anyone know what else ST elevation and AVR is associated with? So it's also associated with left main coronary artery disease or left main insufficiency, and global ischemia. So this pattern presents with people that tend to have sick hearts, or people that are having a lot of increased demand but not increased flow. So this, in the setting of PE, means that, so there's other things on here that suggest that they're having a PE, right? The new right bundle. But this suggests that this is a sick PE patient. This in and of itself does not rule in or rule out PE. But if you already think they have a PE and you do a repeat EKG while you're waiting for them to go to angio because their pain's getting worse, then you see some of these changes, you know that they're deteriorating and they're at risk of slipping into cardiogenic shock. Okay, so what do we see here? What do you see? Okay, inverted T waves. So what else do we worry about with in emergency medicine, people that have chest pain and shortness of breath has inverted T waves? Anything cardiac, right? Cardiac ischemia, see big, ugly, inverted T waves. So is this a PE or is this acute coronary syndrome? Any guesses? We got one for ACS? Well, Tammy's always right, and she happens to be this time. So yes, it is ACS. But the reason is, in PE, you get that pattern on the EKG that I was telling you about. You've got V1 through V4, and in most studies it's lead 3, but 2, 3 AVF, because they're all down there inferior. So you get this kind of J-shaped pattern of where the T-wave inversions are, whereas in ACS, you get T-wave inversions in V1 through V6, typically across the whole precordium, and then also 1 and AVL, because those are also lateral, and V5 through V6 are lateral. So going back to that EKG, you've got your T-wave inversions V4 through V6 and 1 in AVL, that's why this is ACS. So exact same patient with some kind of like moderate risk factors either way. So no leg swelling, shortness of breath, tachycardia, exogenous estrogen use, and some chest pain. If her pattern was V1 through V3 and then 2, 3 AVF inversion, probably PE. If it's this pattern, it's ACS. So that's how you can distinguish those two diseases based on the EKG. Okay. Now, what about this one? Where are the T-wave inversions? 1 through 3, and where else? A little bit in V4. What about here? Yes? No? Yeah, we got something there. So we got this pattern. So what are you thinking? PE. This one's PE. Good. All right, let's move on and talk about hyperkalemia. So what are some of the risk factors for a patient having hyperkalemia? Okay, good. So drugs. There's lots of different drugs that muck with your potassium. ACE inhibitors, angiotensin receptor blockers, DRIs, direct renin inhibitors. Anything that's wrestling with the renin-angiotensin-aldosterone system is going to mess with your potassium. NSAIDs, COX-2 inhibitors, potassium-sparing diuretics, like were smartly mentioned, and succinylcholine. So if someone gets intubated and then paralyzed with SUX and then goes into a wide complex arrest, could be hyperkalemia that caused it. Renal disease was also mentioned. What about another one? Anyone ever been on a scene or heard the story of guy gets in a car accident, pinned under the dash, prolonged extrication, roll off the dashboard, a few minutes later he codes, wide complex arrest, but he was fine for like the hour and a half before that it took to get him out? Anyone ever heard of that story or something like that? Yeah, they go into this wide, ugly cardiac arrest rhythm. So crush syndrome, rhabdo, or prolonged entrapment can also cause hyperkalemia. So normally you've got potassium inside your cells. So that guy in the car accident, when the dash came down and pinned his legs, basically put on bilateral tourniquets, right? No blood flow, acidosis, cell death. Potassium that's normally inside the cells is now outside the cells. And then when you roll the dash off, you're popping that tourniquet and you're giving their heart this big potassium bolus. And so that's why in your 2B protocols, they're talking about preloading the patient with bicarb and running in a bicarb drip when you're extricating that patient, because bicarb is part of the treatment for hyperkalemia. So that's why you do this, is to prevent that patient from deteriorating after you roll the dash off. So in that situation, if you have any of the other tools at your disposal, calcium, Lasix, whatever else, then you can pursue that line of treatment. So someone that codes after a crush syndrome or something, very likely hyperkalemia. Not just limited to crush syndrome. Little old lady falls down at home, breaks her hip, stuck in the bathroom floor for 3 days before her kids get worried because they haven't been able to get a hold of her. But she was stuck with her leg underneath her, and then you like roll her off of it. Same thing could happen. So that's something else to be mindful of when you're moving patients that have been in a position where there's restricted flow to a limb for an extended period of time. Doesn't mean you need to prophylactically treat her with bicarb and stuff, but maybe have a line in already before you move her, which you should probably do anyway if you're a sane human and you're going to give her pain medication before you roll her onto the backboard that's going to give her back pain in addition to her hip pain. But if she starts to deteriorate, you know why. This is a completely reversible cause of cardiac arrest, so keep it in mind. So what are the EKG changes that are associated with Hyperk? So like I mentioned, it's a frequently overlooked cause of cardiac arrest. I don't have hard numbers to put on it, but I've seen a number of cases where the EKG suggested Hyperk, but no one wanted to pursue it until they got labs back. But by that point, you're already, 10, 20 minutes into the code after they've already gotten to the hospital. And so at that point, survival, even if you get them back, you're going to end up with someone that's going to be bedbound, probably not neurologically intact, versus someone that's going to walk out of the hospital in a few days if this had been caught and treated earlier. So some things we actually know about potassium in EKG, or potassium in cardiac arrest anyway, is that the risk of cardiac arrest increases with the severity of the potassium. So for every time your K increases by 1 above normal, your odds of coding increase by 50%. That's pretty bad. So what are some of the things you've heard about hyperkalemia and EKGs? Okay, peak T waves, great. So who's heard EKG is reliable for diagnosing hyperkalemia? No one? Okay, well, a lot of people will preach that you can diagnose Hyperk based on the EKG. Okay, and so we mentioned peak T waves. What's one of the other things that's frequently associated with hyperkalemia? Yeah, YQRS, so that ugly sine wave looking EKG. Has anyone ever heard that the specific EKG changes correlate to a particular potassium level or particular potassium range? Okay, this is in textbooks, where it says peak T waves means that your potassium is between 5 and 6.5, right? That is incorrect. And I'll show you a bunch of cases where that is not the case, because they're really easy to find, because that's usually what happens. Who's ever seen someone use the EKG, probably in the ER, to risk stratify a patient for coding? Like, their EKG was normal, so they're probably fine. So let's say their potassium is 6.5. EKG's fine, they're going to be fine. Versus potassium is 6.5, EKG's abnormal, we need to get moving on aggressive treatment. Okay, so you can use it sort of to correlate with their risk for things, but because the EKG doesn't correlate with a particular potassium level, it doesn't correlate with a particular risk for cardiac arrest. So we already mentioned peak T waves and ugly, wide sinus-looking rhythm. Sine wave, not sinus rhythm. But there are a ton of other things that happen with hyperkalemia in the EKG. Often it's called the syphilis of electrocardiography, or the great imitator, because it can literally do anything to the EKG that it wants to. Flattening P waves, long PR, AV blocks, other AV dissociation, bradycardia, sinus pauses, pacemaker that's not capturing, all these things. Now, these are in a general order of worsening, but any of these can really occur in any combination, any potassium level between two different people. In a given person, they will tend to trend from the least severe to the most severe, but between two people could have the exact same potassium level and have dramatically different EKGs. So to hammer that point home, what do you see here? Peak T waves, okay? Anyone want to guess the potassium? .6. Not super remarkable, okay? What do we see here? Okay, we have a wide QRS, but what else do we see here? Pacemaker spikes. So this guy is supposed to have a wide QRS, right? But how wide is too wide? So the general rule that I like to use is that if the QRS is wider than one big box, that it is too wide to be a bundle branch block or pacemaker. So if it's wider than a big box, one big box, that should kind of raise an eyebrow for hyperkalemia. So the other thing you can see here, you see pacemaker spikes in the middle of the QRS complexes. Pacemaker's not capturing. So the pacemaker is trying to pace this guy twice as fast as it's actually working because every other spike is falling in the middle of a T wave and isn't leading to a ventricular contraction. So you've got a pacer firing in the middle of a T wave. What's this guy at risk for? R on T. He's going to go into VFib. So this is something that probably needs to be treated rather hastily because of this specific risk for him. Not in particular because of the potassium level, but because there's a risk for an R on T because of the QRS widening and the pacemaker not sensing things correctly. So this guy's potassium was 6.6. Now it's a lot higher than the last guy. What do we see here? Peak T waves. What else? Anything with the ST segments? So there's a little bit of elevation, and there's a little bit of elevation along here, and there's a little bit of depression in the inferior leads. So hyperkalemia can also cause ST segment changes. This guy has a potassium of 8, but that's a more impressive potassium, but a fairly benign looking EKG. So in addition to the peak T waves, another thing to throw in on a list of things that hyperkalemia can do is ST segment changes. So you got to run with the history and the physical. So what about this guy? What do we see here? Wide QRS. What's this kind of wavy thing looking like down here? Sine wave. Okay. So this is really wide, wider than a big box, sine wave. We've also got a pacemaker firing in the middle here that's not capturing. This guy also has a potassium of 8, rather dramatically different from the last potassium of 8 that we just looked at. What about this guy? What do you see? Do you see P waves? They're here, but they're flattened. They're low amplitude from the hyperkalemia. And we've also got P waves without QRS complexes, so there's AV dissociation. Also due to the hyperkalemia, also a guy with a potassium of 8. This guy, what do we see? So we've got these big pauses with no atrial activity, and then some escape beats. This is also potassium of 8. This is sinus pauses being caused by the hyperkalemia rather than any of the other changes. So it's really not predictable what's going to happen. What about this? What do you see here? Who looks at this and their first instinct is VTAC? No one? No one's going to admit it? It's not a slow VTAC. Ever hear anyone throw that term around? It's a slow VTAC. I've definitely heard that. physician like, oh, it's a slow VTAC. So this is not. This is someone with a potassium of 9. So this is a really wide QRS deteriorating into a sine wave EKG. If you look at something and like your very first instinct is VTAC, but then you're like, oh, it's kind of slow, think hyperkalemia. Because you're going to shock this patient, shock this patient, shock this patient, and it's not going to convert because it's not VTAC. So hyperkalemia, the EKG doesn't rule it out, but it can fairly accurately rule it in. So 85% specific, which means if you look at the EKG, you say this guy has hyperkalemia, you will be wrong 15% of the time, which is not bad. But if you say this guy has normal EKG, he's fine, you will be wrong 64% of the time. So, I'm sorry, you'd be wrong 46% of the time. So it's not much better than a coin toss for ruling it out, but you can rule it in, particularly in the context of the history and the presentation. So to quote a couple studies, there really isn't a place for using the EKG in guiding treatment. Your treatment should be guided by potassium measurements. So deciding to pull the trigger or to hold back on giving drugs, not really appropriate to do based on the EKG. You should be getting the I-stat potassium. Particularly for patients that are high risk, it's not sensitive to rule it out. The reason for this being people that are on dialysis, if they're already kind of having a higher potassium a lot of the time, so let's say their K is normally between 5 and 6, they may not have EKG changes until much later. So that guy that only had peak T waves with K of 8, that could be your dialysis patient. So in particular, these high-risk people, they may not have changes until much later, which makes it an even worse tool for trying to say you're fine. What do we see here? Big T waves. What else has big T waves that we worry about in emergency medicine? If I say tombstone T waves, does that ring bells? Okay, right. So is this hyperkalemia or is this an MI?
I would still lean towards hyperkalemia.
This is an MI. So a few ways we can tell this apart. Hyperkalemia, the peak T waves tend to be symmetric and concave up. MI, the T waves tend to be asymmetric and concave down. So what that means when I say symmetrical, if I cut this T wave in half, it looks the same on both sides. If I cut this T wave in half, it's not the same on both sides. Concave up versus concave down. This side, shaped like this side, shaped like that, beginning to resemble the top of a tombstone. So smiley face, not MI. Frowny face, MI. It's the easiest way to remember that versus concave up, convex, whatever, however you're going to call it. Smiley face, frowny face. The other thing is on this EKG, you'll get reciprocal changes. So there will be depression in 2-3 and AVF. That doesn't happen in hyperkalemia. So MI will have reciprocal changes. Things that are not MI won't. I'm not saying that this particular morphology is specific to hyperkalemia, but it is specific to things that are not an MI. So this is an MI, this is not an MI, not necessarily hyper K, but if you're looking at big T waves, history that you're kind of concerned for hyper K, this is how you would differentiate between the two. So in summary, if you have anterior plus inferior T wave inversion, think PE. If you have anterior plus lateral T wave inversion, think acute coronary syndrome. If your patient is bradycardic and all the atropine, epi, pacing in the world is not working, think about the potassium. If they're in a wide complex rhythm that you cannot convert no matter how many times you shock them, keep turning up the joules, treat them for hyper K. If the EKG is just weird looking, check them for hyper K. Your EKG cannot rule out or accurately predict the potassium, but if you see it, treat it, because you'll be right a lot of the time. So I see people taking pictures. That's totally cool. You probably want to take a picture of this instead. If you have any questions, please email me. I'm always happy to talk about stuff. You can write down this URL. This is a QR code for the same URL. This will take you to a Google folder that has PDFs of the slides for this presentation. There is a PDF of links for extra places to go for learning about EKGs, the different blogs and some books that I recommend, as well as my outline for this presentation that has all the citations for the research that I'm quoting for these specific numbers. So there's about 13 academic journal articles that I pulled together for this. So with that, does anyone have any questions? No? All right, thanks guys.
Thank you.